Hello guys, this is Dr. T and welcome to Clinical Medicine with Dr. T. So guys, in this video, I want us to talk about rapid sequence induction. Very important topic, and I don't think you can finish your anesthesia rotation without having someone ask you this without being asked about rapid sequence induction, whether in an assessment, in exams, in a test, or just in theater. Rapid sequence. Most anesthesia exams, they have questions on rapid sequence induction because it's very important. So what is this all about? So rapid sequence induction is all about inducing a patient in the safe. It's all about, let me put it this way, it's all about inducing anesthesia as fast as possible and protecting the airway in the process. Like I always say, guys, I'm not a person of textbook definitions. I want to understand a definition. So it's about inducing anesthesia as fast as possible, protecting the airway, and it's usually on unfasted patients. So we already know now the indication that when do you do indication, when do you do a rapid sequence? It's unfasted patients. So you have this patient that is unfasted, and you have to induce them because they need to be operated. So you induce them as fast as possible, making sure that you are protecting their airway. So the main thing here is protecting the airway. So it was discovered that if you have got a patient that is unfasted, someone who is eating, we are going to talk about other group of patients that are regarded as unfasted as well. So if you've got a patient that has got a risk of aspiration, doing a rapid sequence minimizes the risk of aspiration. That's what it's all about. So an unfasted patient, guys, please familiarize yourself with the fasting protocol. I hope I will remember it. But the fasting protocol states that a patient who's gonna go for an operation, they should not have anything. They should be fasted. Most people they are fasted overnight, but the guideline says that at least it must be more than 6 hours. So when they've eaten, they should not go to theater up until 6 hours have elapsed. That's now talking about solid food. And there's a remember, chicken takes about 2 hours to get out of the system, and the beef takes about 4 to 6 hours to get out of the system. The other things, they take much less than that, but chicken is about 2 hours. So 6 hours sort of like caters for most things. That's solid food. And also, when it comes to non-clear fluids and then clear fluids, so with clear fluids, a patient can take clear fluids 2 hours before they go for their operation. So this is 2 hours. So a patient is allowed to take fluids, clear fluids, up to 2 hours before the operation, and then non-clear fluids, I think it's 4 hours. Non-clear fluids is things like juice, things like milk, things like your other drinks, and then clear is like water, right? So this is the fasting protocol. This is how patients should be fasted. If you've got a patient that has not had anything for the past 6 hours, you can regard that patient as a fasted patient. If they've not, as a protocol states that to be fasted, you must have, if you're gonna take clear fluids, at least take them 2 hours. If you're gonna have unclear or non-clear fluids, at least should be 4 hours. If you're gonna have food, then it should be 6 hours. But what happens in the hospital is that patients, they normally have their last meal at like 10 at night. These are the things that are very difficult to deal with practically. So the patient is gonna have their last meal at 10 o'clock. I know that I'm deviating, but this is very, very important. I'm not really deviating from the topic. It's very, very important. When you talk about fasting or a fasted patient, you need to understand what are you talking about. So what happens is that a patient is going to have their last meal at 10 o'clock, and then throughout the night they don't eat anything until maybe they go at 10 for their operation, sometimes at 11, depending how many patients are, sometimes at 12, sometimes even at 2. So this is where we can do better as doctors and nurses when it comes to these protocols. But sometimes you don't really know which patient is gonna be number 1, number 2, number 3. But I think if we can sort of like sit down and say this patient is gonna be number 1, this is gonna be number 2, this is gonna be number 3, then you can allow other patients to have clear fluids, to have non-clear fluids while they are waiting. The problem with this protocol is that it's not followed as it's written. Patients, they usually don't take anything from 10 o'clock until the next morning. The problem with this is that you can have hypoglycemia while waiting for operation. It's possible, but the major problem is dehydration. Remember, once you are dehydrated, you can start having electrolyte imbalances, problems with sodium, and then you are behind in fluids. By the time you get there, you are dehydrated, especially if you don't have an IV line, right? Especially if you don't have an IV line. So yeah, that's that. Now let's get back to the issue. So now, other patients that are regarded as unfasted, I think I've been mentioning this a lot in the videos. Pregnant women, people with diabetes, people who've got diaphragmatic hernias, Okay, now why so basically these patients, because they are regarded as unfasted, they have got a high risk of aspiration. That's why they need to be done rapid sequence, right? Someone who's diabetic, why would we regard someone who's diabetic as unfasted? Because of people who are diabetic, they get autonomic neuropathy, and because of that, they have a reduced gastric emptying. So that's that. And then pregnant women, the same reason, they also have reduced gastric emptying. But on top of that, their lower esophageal sphincter is also very unstable. They get relaxation of that sphincter, and that easily allows gastric contents to come up and get into the esophagus. So that's basically that. So if they ask which kind of patient would you do a rapid sequence, you're gonna talk about those patients. Unfasted patients are usually patients that it's usually emergency patients. Let's say you are driving your car, you get an accident, then you need operation, whatever injuries that you got, and then they need to be operated. You are unfasted. Let's say you're just walking and then you fell, or you're just walking in town, you got stabbed. You are unfasted. I mean, even if you can come in and say, the last time I ate was this morning, it's okay, it's beautiful, it's fine. But most doctors will still do a rapid sequence, because your fasting we cannot trust. The fasting that you can trust is a fasting that was done in the ward, that actually the sisters were there, they did make sure that the patient didn't eat. That's the fasting that you can actually trust. Other than that, rapid sequence. Okay. So now, so we do rapid sequence because a patient who's unfasted needs operation, and we know that they've got a risk of aspirating. Now, how do you do a rapid sequence? It's going to be very practical, guys. Patient comes into theater, the operating room. You transfer the patient from their stretcher onto the operating table. From there on, the patient is lying there. Number one, make sure that they've got an IV line. The IV line must be reliable. Don't just make sure that they have it, but make sure that it's running. It must be running. It must be present. It must be running. It must the cannula must be of a good caliber, like your gray, your green. If not your gray, pink is the last option. So you make sure. There are some doctors who will be like, all patients that come in must have 2 IV lines in case the other one fails. But yeah, not everyone is so strict about that. So as long as you've got one line that is reliable and that is working well. So these are the practical things that you would do. I mean, for you to make sure that the IV line is running, you don't have to wait for a medical officer to do that. You can do it while they are still busy with other things. Even if they are not in theater when the patient came in, you can still do that. And then attach the monitors. Attach the monitors. The monitors that you attach, it's your NIPP. NIPP, it's non-invasive blood pressure. Remember, they are invasive blood pressures, but this one is just the one that you put a cuff around a limb. You put your SETS probe, you put your ECG leads. This is basically that. Any other thing that your senior thinks that it's important, they will tell you to do it, but these are the basic things. From then, obviously by this time you have already prepared everything, because when the surgeon called you as the anesthetic team on call, they would tell you that we've got this patient that we want to see, and then you would go and do your pre-op assessment, and then you come back, you prepare your drugs. So by the time the patient comes in, all the drugs are available. The drugs that you're going to use and also your emergency drugs are available. We are going to talk about emergency drugs now. And then the next thing, if we are happy that our blood pressure is working, we're getting good readings, it's a good practice to record your blood pressure, your vital signs, before you induce a patient, so that you can know where you are in terms of your vitals. You can know where you are. You get like your baseline vitals. And then when everyone is happy, we've got the equipment, everything is available, you will pre-oxygenate the patient. Pre-oxygenate the patient. Pre-oxygenation is you give a patient 100% oxygen via a face mask. You do that for some books, say 3 to 5 minutes. Some say the patient can take about 3 vital breaths. But most of the times we do 3 to 5 minutes. This is what we are being taught where I'm currently working. So the breath thing is not what we follow. We do the 3 minutes, 3 to 5 minutes. Okay. Pre-oxygenate. And then when you've pre-oxygenated, so what is the idea behind pre-oxygenation? What you want, they call it nitrogen washout. That's another word for it. They call it nitrogen. Maybe not like this. They call it nitrogen washout and oxygen wash in. So basically, you are trying to take out all the nitrogen in those lungs, so that you replace that nitrogen with as much oxygen as possible. And the reason why you do that, you want to make sure that this patient is well oxygenated, so that when you are intubating, trying to find the cords, at least the patient will take a longer time to desaturate. Imagine if you don't pre-oxygenate and the patient has got like let's say 85 or 90, the SETS is like 90 or 80, or let's say 90. If you take longer to intubate, you might find that by the time you're intubating, the vitals, the SETS have decreased so much that you need to resuscitate now. So that's why you want to push them as high as possible, so that you have got time on your hands, a bit of time on your hands, to actually find those cords and intubate. So when you are happy and your senior is happy with pre-oxygenation, the first drug that the doctor is going to give. So when you do this, you need about 3 people, especially if you are not experienced. So you need about 3 people. For people who are experienced, 2 is enough. The one person is going to be the one that is going to be holding the mask and making sure that the mask is sitting tightly, nicely around the nose and the mouth. And that usually needs about 2 hands if it's an adult. And then you need someone who's going to give the drugs, and then you need someone who's going to do the cricot pressure. Like I'm saying, if you're experienced, two people can do it, but at least a minimum of two people have got to do this. So the first drug that that is gonna be given in this patient is gonna be an opioid. Let me not say opioid. Let me say you're gonna give a drug that is used to blunt intubation response. Blunt intubation response. The reason why I said an opioid is because most of the times it's an opioid, but there are other drugs that are used as well. So the opioid of choice there is fentanyl. So you give fentanyl to blunt intubation response. What is intubation response? When you actually, it's a stress response that a patient gets, and when they get that stress response from the intubation, they tend to release a lot of catecholamines, norepinephrine, or adrenaline, and then those are catecholamines. So once those are released in huge amounts in the blood, they increase blood pressure, they increase the pulse, and now you've just made them to be hemodynamically unstable. This is hemodynamically unstable. And when that has happened, they can have an increased intracranial pressure, they can have remember, once you get you can even get a heart attack with this. Once you get like a severe tachycardia, and you can even start developing some kind of arrhythmia from that, a tachyarrhythmia. So anything can happen.